afternoon, everyone. My name is Andrew Blustein, and I'm the chair of Garfunkel Wild. I want to thank everyone for attending. This is our session on selecting, implementing, and controlling AI in healthcare. And what we're going to do for about the next 45 minutes is talk about various topics with a mind of you're out there, you're in your healthcare organization, and you either have some AI or you're thinking about bringing in AI. And so we're going to talk about what is AI, how do you evaluate it, how you test it, what diligence should you do, what can you do to protect yourself both contractually and operationally. And we have an excellent panelist to help us do that. First up is Dr. Matthew easy for me to say, Shafiroff, who's the Chief Medical Information Officer at White Plains Hospital, which is a major hospital in Westchester, New York. Matthew has both the clinical know-how. He's a board-certified clinical informaticist and emergency medicine physician, but he also has 2 decades involved in health information technology, and he's very involved in trying to determine what empowers patients and non-patients in the hospital to use the most they can from technology. And he spends time also with East Post Road Ventures, which is a healthcare technology and patient experience company affiliated with White Plains Hospital. So Matthew, thank you so much for bringing that perspective. Also, we're joined by Hassan Khan, who is very experienced. He's a technology consulting partner with the Grassi advisory group, and he leads their technology advisory practices. So clients come to him for all sorts of selection and integration and things like that, which we're going to learn about. And he's been doing that for about 20 years. And so he's an expert also on technology and regulatory compliance. And prior to joining Grassi, Hassan was a managing director at a national accounting firm, and he's a licensed system auditor and a whole bunch of other impressive degrees. So we're happy to have him as well. And then last but not least, because it would hurt me, I have my partner, Terence Russo, who is the chair of the Technology and Cybersecurity Practice Group here at Garfunkel Wild. And Terence spends a lot of his time, well, probably all of his time, reviewing technology contracts that are given by hospitals, ASCs, nursing homes, you name it. And so he's at the forefront of the changes that are occurring regarding AI and beyond. So with that, I'll start with Matt. So Matt, when somebody says this product has AI, what does that mean to you? We'll start with what it means to you, and then Hassan, I'll ask you to follow up with the same question.
Sure, great. Thank you, and thank you for the kind words, Andrew. I'm glad to be on the panel today with Hassan and Terence. So when we're brought artificial intelligence in air quotes projects, artificial intelligence can mean a lot of things to a lot of different people, depending upon your level of knowledge and sophistication in the field, because artificial intelligence in and of itself is a large field. Goes back well over 20, 30 years, encompasses things such as machine learning, which algorithms, deep learning, neural networks, and now implementing both ambient and generative AI. So we're using artificial intelligence to generate typically text or other outcomes. So when someone says they're bringing us an artificial intelligence project, typically what does that mean to me? Well, I go back to the typical rigor of any type of project. We want to understand what's the problem, what's the goal that we're trying to solve for, and then what are the technology tools that we're going to implement to attempt to solve these problems, and then who are the people and who are the processes that are involved. So artificial intelligence is just a tool in the toolbox of problem solving for clinical teams.
Okay, so Hassan, can you comment on that, and also why isn't it just computing? What's the line between computing and AI?
Yeah, thank you, Andrew. I'll actually further all of Matthew's comments because that's exactly right. Artificial intelligence is a very broad, holistic term at this point. There's a whole plethora of different algorithms, large language models that are being utilized. To me, when people say that we're going to embed artificial intelligence, it's really there's twofold. One, you can get away from the mundane task of, as an example, picking up a invoice that comes in your inbox all the way from getting it paid from your bank, that entire process automation. To me, that's artificial intelligence because it can recognize a certain vendor, it can pick it up and send it out. Furthermore, being able to garner insights that you wouldn't otherwise. You have this huge database, let's call it that. You have different systems within your hospital system, your clinics. How do you ensure that you're getting all the insights that could prove to be actionable and assist you in making your businesses more efficient than in the past? So actionable data and process automation, to me, that's artificial intelligence. So if a vendor comes up and says, we have this new EMR and that it is AI enabled, well, let's see if they can showcase exactly what that process automation looks like.
So you're looking, both of you use the word learning. You're looking for the product, if it claims to be AI, to actually be thinking. What does that mean? What does learning and thinking mean in an AI?
So broadly speaking, the definition of artificial intelligence is the ability to use computers and computing power to approximate and or mimic, potentially exceed the human thought process, right? So we're teaching machines essentially how to think like humans, because with computing power and essentially a potentially massive lake of data from which to search from, the thought is that the machine can assist or automate processes that are otherwise mundane, easy to solve, and particularly potentially in the future even more difficult to solve. But it's that process of teaching a machine how to think and or reason like a human being.
Okay. Terence, and I'm going to come back to, we're going to get into obviously taking these theoretic concepts and how do they actually bear down on healthcare. But Terence, how many years ago was it when you first started to hear or receive contracts with the claim that they were AI-based contracts, and when did you start to see that speed up, and where are we now in terms of your volume?
Okay, yeah, I'd say I started seeing AI contracts very infrequently 4 or 5 years ago, but now it's really speeding up. I think it's increasing. I would say about 10%, maybe even 15% of my contracts have some AI component in it, or at least that's how the sales rep is presenting it. And like Matthew and Hassan, you have to always kind of say, what is it really doing? You can't just stop at the moniker. But I'd say it's 10 to 15%, Andrew. I'm seeing it mostly, the most common areas I'm seeing where there's real savings are rev cycle. I've seen AI do coding because people are having a hard time getting qualified coders. And some of this AI coding guarantees a 98% accuracy rate. You can only get a 95% from human coders. So, some things are better. Scheduling, prior authorizations, eligibility verification, a lot of this automation, you're starting to streamline it, speed up the revenue cycle process, and cut down on personnel costs. I've seen it in call centers. I've seen virtual scribes in terms of an AI that listens like Siri and filters out the conversation between the doctor and the physician so that the physician can actually look at the patient in the face rather than be staring into a computer screen, typing up notes. So all sorts, I've seen marketing now. I'm starting to see more and more AI marketing where it's interfacing with the client relationship manager to make sure that people aren't missing their follow-up care. Client decision support. I'm seeing a lot of different things, Andrew. And I think it's gonna bloom. It's gonna balloon more and more.
Matt, are you seeing those same kind of use applications, at least at the hospital, being offered for the hospital to use?
Yeah, so we see a wider range of artificial intelligence programs being brought from market to the hospital in areas as was previously mentioned by Terence, a lot in revenue cycle management. We're seeing a lot in CRMs, especially around the concept of an ambient tool that is listening to a conversation, ensuring that the hospital agent is appropriately discussing the items that are meant to be covered on the phone call, and then trying to gather some sense of sentiment about the call, right? So it's both a tool that assists the employee at the hospital to ensure that they're touching all the proper things, and then gives them feedback on the call. Was it well received? What was the sentiment? What could they do better in the next time? So we're seeing these, in what we'll call non-clinical areas, but we're also starting to see now a significant number of projects in clinical areas. Historically, radiology and computer vision has been ahead of this, but as computer vision has accelerated, that means that a camera typically is looking, or the computer has an image on it, and it's garnering insights through the artificial intelligence application about the imaging. We're starting to see things like fall prevention through decubitus monitoring through cameras. And of course, we're seeing ambient tools and virtual scribes, as Terence mentioned, that now assist physicians in helping them craft progress notes and other forms of documentation that typically would cost them hours. At the end of the day, this quote unquote pajama time. So we now see that ambient intelligence linked to generative artificial intelligence can essentially listen to a conversation, pick apart that conversation, craft a traditional SOAP note or a subjective objective assessment and plan note, much like any physician would write, turn that around in less than 5 minutes, and have it integrated into the electronic medical record, waiting for the physician to review, edit as needed, and sign off on.
So, wow, that's fascinating. So, Hassan, I'm going to take that last part of Matthew's comment and come to you talking about scribes. So, I'm somebody listening to this, and I remember what a dictaphone would be. Why isn't this just a glorified, for having a scribe, why isn't it just, two questions. One, why isn't it just a glorified dictaphone machine? I'm dating myself to remember what a dictaphone machine is. And two, how does this really help the doctor?
So how is it and why is it a glorified dictaphone machine? I think it's able to, and I know exactly what you're referencing, Andrew. It was able to pick up your voice and not maybe able to ascertain the exact specificity of the messaging. I think AI, because of its huge, let's call it a database behind it, it can read through the lines and pick up the context of the conversation and be able to send that messaging across, either in a written form or a verbal communication in a much better format. And we had spoken about this earlier. It's learning as it goes. So as you are, this is now the 50th time that your AI scribe has heard you dictate notes to, I don't know, your resident. It has picked up who you are, how you speak, your specialty, and then it focuses in on that. So it's learning with you, and the output is going to be a lot more specific than some of the technologies that we were using 20, 30 years ago. Andrew, sorry, there was a second portion to that.
No, I think the second portion, that's excellent. Matt, I think the second point, given that you are a physician, your personal view, not necessarily that of White Plains Hospital. I should have said that at the outset. You're not speaking for the hospital, but as a physician, do you want a virtual scribe? And if so, why? And if not, why?
Yeah, I think that so virtual scribes are great. We've had physical scribes in the past. The beauty of the virtual scribe is that you can attempt to connect with a patient more at a human level. You can unburden yourself from potentially remembering all of the little details or this or that because you're going to have to write it down. You can listen to the patient. So you can, and then you can listen to more than just their words, because the words are captured. You can look at their body language. You can understand how they're carrying themselves in a conversation. You're able to make a more human connection with this individual instead of carrying necessarily all of the cognitive burden of trying to remember all of the specific details about the history of present illness to make sure that you captured them correctly so that they can be recorded in the chart. Because one of your responsibilities, of course, as a physician is crafting a progress note that reflects the conversation that you had with the patient. And of course, you can't do that in a verbatim method. You need to listen to it. You need to interpret it. You need to then place it down in thoughts that are not just for yourself to remember later, but for anybody else who picks up the chart and reads it to help understand what was the discussion, what was your, what were your findings, and then what was your thought process moving forward. So I'm very bullish on this ambient intelligence and virtual scribes.
Okay. Hassan, there's the positive. That's the promise of AI, which we'll unpack more as we go through this. But what are some of the negatives?
There's a couple that come to mind, and would love to hear from Matthew and Terence as well. But to me, there's one thing: we're getting away, and we should get away from public AI, meaning trying to ask ChatGPT to give us an answer. I think it's great. It gives you the foundation of what you're looking for, but it's not going to be specific to you. It's the public internet. Could be false, not the right way. Private AI, especially in healthcare, is going to be the way to go. With that, AI is nothing more than another piece of technology that you're going to bring into the network. What that does is it opens up yet another port or a porthole for nefarious entities to come in, because it's just another piece of technology. So cybersecurity it's been on the forefront for our clients, our constituents. I feel we have to be even more cognizant of it, because you're instituting yet another piece of technology that is very, it's going to be fairly voluminous and exhaustive. It's going to touch a lot of different things, your different EMRs, your ERPs, your data bases. So ensuring that we have cybersecurity locked up will be critical. Privacy and associated regulations are going to be, should be really top of mind. European Union's GDPR came about back in May of 2018. The state that I'm a resident of, I know some of you are as well, New York State now has the New York Shield Act. Really what all of these regulations is saying, that we need to have a better control of our PII, our personally identifiable information. We have had HIPAA for a long, long time. What this is saying is that we should be in a position to be able to identify where our data is resident, categorize it, remove it if and when need be. And then furthermore, there's a cybersecurity element to it as well, that if you're breached, who do you notify, in what time frame, and what are some of the things that you have to do thereafter. So cybersecurity, privacy, absolutely things that we should be cognizant of. And then we can get into it later, but deep fakes, be it a video that I'm receiving or a voice note, ensuring that Terence actually sent me a voice note and it's not once again, a nefarious entity trying to make their way through. Because AI, any piece of technology, I feel, if used for nefarious purposes, can really have a damaging impact. So reputational risk, financial risk, that's all going to be in play with AI.
Okay, so I'm going to come to you now, Terence. I see the positive and some negatives. You get a contract, they say it has AI. How do you address, let's say, two of Hassan's concerns? The privacy security part. Well, let's start with that. How do you address that? And then, actually, I'll add to it, the privacy security part, and then the malfunctioning part. It's just not working.
That's a lot to unpack, Andrew, this in a short call, but there's a lot of things we do high level. So first of all, when on the ambient monitor, I just want to say one of the benefits is the physicians don't have to do their notes late at night, which is super nice because there's a lot of burnout. And I think it's actually going to help that. The one thing everybody mentioned is there's always almost a human in the loop. The human signs off on the scribe on the note. So you still, I'm not really, so you do have to monitor and make sure we're always concerned, Andrew, with AI
Yep.
drift or hallucination. And Hassan referred to that generally with the whole public AI and, what the data is, the AI is only as good as the data from which it draws from. And when they start taking from everything with no selection, you're going to have you could have bias, you could have a whole bunch of problems in there. So what do I do? But cybersecurity is a huge problem. Um, the financial industry is way ahead of the healthcare industry on this. Um, change, the change fiasco when a lot of places could not send out claims for 2 to 3 months showed us how fragile the system is. So yes, there's a lot of cybersecurity provisions I add to the standard contract. Multi-factor, updated firewalls. The data stays in the United States. I need to know who is in the data flow, who is touching my data, because there's so many subcontracted entities in there. Sometimes people don't even know. Some hospitals and healthcare providers don't even know who's hosting their data. So a lot of things we have to focus on, Andrew. There is going to be a federal law coming out. There was one in New York State, the just for general hospitals, just came out about 2 weeks ago. Federal law, we've been hearing about it. It's coming. There's going to be an update to HIPAA. The HIPAA security rules are very outdated. They're very 1998, and things have changed. So yeah, I focus on data security provisions. I focus on cyber insurance. I tell people, when you're choosing a vendor, you've got to start asking the questions. You can't just say, okay, you're telling me you're robust, you have reasonable protocols, security protocols. That's not enough. We have to get granular. And a lot of our clients, the more sophisticated clients, are sending out security questionnaires now to actually ask the vendor, what are their
Yep.
real life security practices? That's going to become standard. I think that should be standard for most of the large organizations. Smaller hospitals can't really deal with it yet, or smaller physician groups, but that's coming. So that was a lot. I know I gave you a lot there.
No, that's all good. So I'm gonna come to Matt, because you touched on other things. Because where we've moved the conversation, just to keep track of it, we talked about what is AI. We whetted the audience's appetite a little bit on some usability. Now we're going into selection. So, Matt, you have somebody banging down your door within the hospital. I want to get this AI product. What are the diligence concerns you have, hearing what Hassan and Terence have said, and how do you start to go about the diligence?
Sure. So the due diligence in any type of artificial intelligence project is similar to any other type of information technology project, as far as I'm concerned, right? We need to first have a thorough understanding of what's the problem that we're attempting to solve, and how do we know that we've solved those problems? What are the goals of the project, right? So a thorough understanding of that, because we have to take the right tool, right, and apply that to the problem so that we get an outcome. We have to understand the people that are going to be involved in the project. We have to have some sense of what are the processes that we're going to surround this new technology tool with, so that the people who are solving the problem using the tool have a process that actually works for them. And then we have to begin to understand the product itself, right? How was the product built? What was the underlying data with which it was built? Where did that data come from, right? To some extent, you may want to ask about the training that occurred, right? If you have the technical know-how, or people in the team that have the technical know-how, you want to understand how sophisticated, and there are numerical ways of understanding, right, how reliable the model is. So how often does it give you a true positive, or how often does it give you a true negative? Understanding those types of statistical returns on the tool and the technology help give you a sense of, how well does the model perform, and what was the scenario in which the model was trained so that it had that performance. Because some of the issues that you get is that you just can't take data from anywhere. Like, all data, even in healthcare, most data is local, right? The people and the populations that you're treating, they're different throughout the country. So you have to have some sense of, where did this data come from? What were the people like? What were the processes that were used? How much data do you have? Did you collect data from lots of different areas, so that when you take a model, you have a fairly good sense that the model was robust enough to answer the problem. And then when you get into, if you've decided that you've made the right vendor, then you have to do the diligence of, okay, maybe we want to move forward, but how do we know that your product is actually going to return what you said it will do, right? And then that's a matter of, can you test with the vendor? Can you provide them with some sense of data that lives in your system in a safe and secure method, perhaps de-identified, and run your data through their tool to see if you can recreate the results that they generated with their model being trained elsewhere. So, that's that's a lot too. I've covered a couple of different phases there, but you want to definitely make sure that you do your due diligence, both with the product that you're being presented, understanding the ecosystem and the other tools that are available with that ecosystem, and then essentially taking whichever tool you decide upon and making sure that that is going to actually work in your ecosystem before you do a full-blown implementation, because there's time, scope, and money. Every time you take a wrong step, right, there's opportunity cost that's involved. And all of our organizations are pressured to put in technology and move forward because it's the lifeblood now of how we operate. So we just have to do our proper due diligence and ensure that we're being judicious and take the right steps forward.
Okay, so Hassan, Matt is looking at a product and he comes to you. I take it that's what you do, morning, noon, and night, right? So they come to you. Is there two questions? Is there a particular concern? You heard what Terence said before, that especially in healthcare, a lot of these AI companies are new, 4 years old, 2 years old, whatever. Does that produce special challenges? How do you deal with that diligence? Well, let's do that, and then I'm going to come back to what Matt was touching on, which is how do we deal with integration and it's not just a product in a silo. So let's just first build on what you do for due diligence, which is what audience members listening should try to do if they don't hire somebody like you.
I'll use Matthew as an example. Matthew comes across a vendor, has never heard of this entity before, doesn't really know who the individual is, and so forth. As you're going through the diligence process, I would take has been unable to provide any references because there are no references. They literally started this, organization a month ago. If anything, White Plains Hospital will be the first client that they are going to have. I would really look and see as to what the leadership has done in the past. Have they ever, have they been involved in AI? Are they technologists? What have they done? Who have they done it with? I mean, if this is a 18-year-old, individual, then maybe I would be extremely apprehensive. But you're conversing with a person that's been in the industry, has been a technologist. He or she, I think, looking at credentializing what this entity has done in the past, I think will be extremely critical. And then most startups, especially if they're in AI, I feel they probably have some backing from a VC. There's some seed funding, there's angel investors, there's probably a private equity shop that has a vested interest. I would see who they are, because I think that will also further credentialize that, I don't know, if KKR has done their diligence and they agree with it, then, I'm kind of sort of basing my decision on some of the other industry experts as to what they believe in it. I'm going to go back to Matthew laid it out very nicely as to the thought process when you're taking on any new piece of technology. As long as you have your functional stakeholders involved in the decision-making process, they get to touch and feel the solution. They get to see how it will assist you. I think that in of itself, along with the people that you'll be working with, is going to be a success. So I would not be apprehensive if it's a brand new AI startup, as long as the leadership team at that AI is adequate. They've been in the industry for a while, good, adequate backing, and your functional stakeholders are behind it and they see the value proposition. I think we're in good shape.
So that's an interesting way to do it. Look at the leadership. But Terence, let me come to you. I've walked by your office and heard this similar conversation many times, where the client, let's say not Matthew, is saying, but the salesperson told us this, so I don't care that it's not laid out clearly in the contract. How do you respond to that?
Well, those if a salesperson makes a representation and it's not in the contract, it's generally not legally binding at all. Sometimes we find old emails, where or an old sales pitch deck or a PowerPoint. We say, look, you kind of said this, you implied it. You're not going to win that. You're not going to make those terms enforceable. So what I like to do is I like to find out what is the real deliverable, what are we really getting, and if I'm not getting a contractual assurance for that output, then I'll even draft it. I'll work on with the stakeholders to make sure this is what we need. This is how we know whether this works or not, whether there's going to really be a return on investment. So yeah, there's a wide, and I don't think it's even malicious. It's just communication, and salespeople get excited about their product. It's a little bit of puffing, but you can't rely on that. You have to get things in the contract, and the other parts. I totally agree with Hassan and Matthew on the process. Looking for the problem and then following the data flow, making sure it integrates. We'll talk about that. But Andrew, the basics contract issues when I do this, other than cybersecurity, I want to get a termination for convenience, and I want to make sure that startup has cyber insurance. That's a big when because things go wrong. You're dealing with a lot of data out there, so
Okay,
things
but
go wrong.
the takeaway is what a salesperson tells you, while interesting, has no legal implication to your contract. Not in the contract, it doesn't exist.
Doesn't exist. There's a merger clause in every contract that basically says if there's a representation on this subject matter of this contract, it's void. It has no legal precedent. Almost 99% of the contracts or
Yeah.
more have that provision, and people fall for that all the time. You can't.
Matt, you wanted to say something?
No, there is yeah, to follow up on that, there's a great information technology cartoon that basically just shows like the difference between what the vendor sold you, right? What the clinical team thought they were getting, what the IT team actually implemented, and then what the operational team actually needed. And they're all like sort of the different variations on the same kind of theme, right? So they all look slightly different. You don't not really sure what you're getting until you get the end state, but you really need to, go back to understanding what do you need and how is it documented, and are you actually going to end up getting what you need, not what you were sold.
Right, and this is going to sound like a shameless plug, which it is, of course, but it makes the point. One of the areas of our firm that's expanding is our technology litigators, because out of that toxic confusion that you just described comes lawsuits. You said this, no, I didn't. I never promised this. So hopefully, nobody who's listening to this broadcast will get there. So let me pick up. I'll come to Matt, you, and then to Hassan. Before, Terence mentioned a word drift, hallucinations. Is that true? What is it? Why does it occur? And does that mean we can't really use these products in a clinical environment?
Oh, would
Matt?
you like me to start?
Yeah.
Yeah, sure. Yeah. So, no, drift and hallucinations are natural byproducts in many ways of various types of artificial intelligence. Typically, when we're talking about drift, what we're talking about is how a model is trained on a certain subset of data, and over time, um, the data may change because people change, right? And disease states change, and how we collect information may change a little bit. So, as as we evolve clinically, right, the model was trained on X, it has an understanding of X, but over time that model may not fit and perform in the same method as it did before, and that's what we refer to as drift, right? So it's important when you're working in an artificial intelligence that's basically machine learning, maybe even deep learning here, that you have a good relationship with your vendor, that your vendor is constantly communicating with you, that you have good feedback from your clinical teams about how the models are operating. Are they operating the way that you intended to? Are they still operating the same way that when you implemented the product they were operating? So that over time you can go back to the model and they can retrain the model based on the data, so that it continues to provide you with the output that you are looking for in a repeatable, a reliable, and accurate method. So drift is a real thing. You have to monitor for it, but there are technology tools and methods that can correct for drift. When we talk about hallucinations, that's typically a term that we hear in the generative artificial intelligence world. And essentially what a hallucination is that remember, these GPTs or generative AIs, they're basically just word predictors trained off of millions of words, petabytes of data, but essentially they're looking to predict something. And the machine is going to provide you with an output, whether that output is factually true or not, or if it can find information that predicts the next sentence based off of the question that you ask. So hallucinations are real. The level of which a model hallucinates often can depend upon how it was trained, how expansive the training was on it. And then there are techniques that you can apply, and this is where understanding, what the vendor is selling you, what the level of training that they did, and really you need to have somebody in many ways that has some technical experience, but you can go back to a vendor and you can ask, okay, this is a generative, does it hallucinate? And if they say, well, all generative AI hallucinates, so you can go back and you can ask them, okay, well, is your model fine-tuned? Is it fine-tuned on specific data, right? So fine-tuning is a word you want to get familiar with. You can ask it about the temperature of the model, right? So there's certain temperature can be hot or cold, right? And those different degrees of temperature basically tell you, well, the model is going to be very conservative, right? If it's cold, and it's less likely to hallucinate than a model that is hot, right? But cold models have their drawbacks as well. They may take a lot longer. You can ask it about prompt engineering, right? So how do I prompt the model when it's doing, and what prompts did you take, and did you use tools like, here's another term to perhaps familiarize yourself with. Is it zero shot prompting, or is it going to do multiple levels of prompting, so that the machine starts to think, okay, here's the question, how would I approach that question? And then what's the next question I would ask? And then what's the next question that I would ask? And through that level of prompt engineering, whether you're doing it as the human or whether the machine is doing it, you're starting to reason, right? And this is, we go all the way back, remember we talked about artificial intelligence, it's the attempt to use computers and computing power to begin to think and perhaps reason like a human being. So the more that generative AI can reason like that through prompt engineering and through zero or multiple shot learning attempts, then the less likely it is to hallucinate. But yes, these are real things, and you have to be cautious of them. Your end users have to have some knowledge that they may exist, and that's again why in the clinical world, where this is, and we've said it before in this, it's always assistive intelligence, right? It's there to assist the physician, and ultimately the physician still needs to be the supervisor. We would never attempt to unleash a model clinically and not put a physician behind the wheel driving the car.
Yeah, and from what I'll just say as a lawyer, which I am sometimes, the excuse, well, the machine told me this, doesn't get you out from under. You still are responsible for what your machine does. So I get having to keep the physicians involved. So I want to shift the conversation. We've spent some really good thoughts and time on the diligence part of it, asking those leadership questions, looking at the product, asking, the hot, cold questions, Matt, you just came through. I want to go to testing a little bit. Hassan, I got a client come to you. I'll just keep making Matt the client. He comes to you. And what does testing look like? And when the salesman says, no, this is good to go from the get-go, don't worry, it's plug and play, we hear a lot. How do you respond to that?
Testing is critical. Once again, I think this is technology agnostic. So equally critical in AI as compared to installing or implementing a new EMR, which is to really go through the second to last, I would call, phase in your system development lifecycle, which is UAT, user acceptance testing. That's when your functional stakeholders, the people that are going to be using this on a day-to-day basis, get a chance to play in that system and try and break it. So what they're trying to do is their day-to-day operations of, as an AI scribe, making sure that if they're going to use that scribe 20 times in different circumstances, then they actually in UAT, they make sure that they go through all those different scenarios so that when they go live, let's call it a month from now, They've tested it, they like it, they approve it, and they're good to move forward with it. In between UAT and going live, or when go live, go start date is, there's a staging environment where you can play around with the data more. So you have all these test scripts that you've gone through in UAT, but you still ad hoc can play around in staging with test data. So it's your data that's maybe scrubbed or something that the vendor provided. Play around with it, see how you like it, and then go live. So testing will remain critical in AI, or I would rather say any piece of technology that you're ever going to implement.
Okay, I'm mindful of the time. That's awesome on testing. Terence, how do you, or what do you try to get into a contract to give Hassan's recommendation voice in terms of testing?
Well, usually you put in the contract where we don't have to go live until we, the client, say we're ready. There's never, I don't want to be pushed in by the vendor who wants to start charging us their full fees. It has to be the customer, the end user. And you have to put additional, I like to put contractual warranties in there about updates, patches, etc. Because we all know, remember when CrowdStrike, it was a patch or an update that hadn't been adequately tested with enough people. So sometimes vendors do things too quickly. That's just one example. I would also say, yeah, don't the references are enough and demos not. I like Hassan said, you use the real data in a test environment, a development environment. We usually put that in the contract. Sometimes you'll say we're gonna have 3 instances. We're gonna have a sandbox, a development instance. We're gonna have a live production environment. All sorts of some places have 5 instances, for a bunch of reasons. So I'm on the same page, and there are contractual assurances, Andrew, that you can put in to make sure you're getting these extra protections.
And I take it you're also fighting about the acceptance criteria that Hassan mentioned, right?
Yeah. No, what is the deliverable? When is something really ready to go? And sometimes there's go live, and there's testing, there's pre-live testing, there's go live. Sometimes there's an acceptance testing that is even after go live, because once you put in the actual data,
Yep.
there's often little quirks or things that, it worked great in test and development, but in live it's not. So I like to have a post go live milestone, and I tie it to payment or termination rights if it's just a disaster. There's all sorts of things, but you have a post go live milestone where you have certain rights. They're not handing you the keys and say, okay, now go do what you want. You worked in test. That's not enough.
Okay, so
Yep.
we have 2 minutes left, so and I'm gonna come to Matt with this. So we've figured out what AI is, we've analyzed our goals, we spoke to leadership, we did our diligence, we tested it, we gave it to somebody like Terence, to make sure the contract has warranties and all those other things. So now it's in, Matt. Can you pick up on Terence's thought of, so now we're going forward, updates, maintenance, check-ins, those types of things?
Yep. So as Terence said, right, this post go live, what we'll call, we often will run a lot of the machine learning algorithms, what we call silently, with live data, meaning that it's in the live environment, it's getting live data. It's actually implemented, but our clinical teams aren't necessarily seeing the recommendations of the machine learning algorithm or the tool yet, because we're then going to, as Terence said, we're going to 6 months later, we're going to see how did that algorithm actually perform in the live environment against what we did, right? Against what we found. Like you see this often in radiology tools. Like you'll run the tool silently. It looked at 1,000 chest X-rays. It said 940 had no pneumonia, and the other 60 had pneumonia. And then we look at what our radiologist said, and is there concordance between what the machine said and what we agreed? And if we agree that there's concordance, maybe at that point we're going to, where there's a little bit of overlap, and then we look at where there was discordance and who was actually right, and then we'll turn the algorithm on and put it in the live environment. But right, you just can't walk away at that point, and we've talked about the problems with drift and other things, especially in machine learning algorithms. So it's really important that you maintain the proper relationships with with both, from the IT perspective, with both the vendors and the end users. You're going to want to schedule regular check-ins. You're going to want to maybe understand the health of the tool. at certain points, maybe 6 months, maybe a year. Oftentimes you may want to do this around things like updates, right? Because that's a good time where you have the vendor in and you're going to say, hey, let's see how this is performing, just to make sure that we really are getting the output and the clinical efficacy that we paid for in a project. And, the projects, they can go right for a lot of reasons. They can go wrong for a lot of reasons. All of that rolls back to, did you do the proper diligence? Did you properly align people, process, and technology? Incentives, are they properly aligned? So, it's often more, unfortunately, sometimes it's not even the technology, right? But that's what happens if you don't. You really need to do the diligence properly, understand how the operational team is going to work, and make sure that they can leverage the technology tool in a way that delivers a better outcome than you were receiving before you put the technology in.
Okay, I'm going to leave us on a cliffhanger. Hopefully everyone will come back at 3:30 for the live Q&A. The cliffhanger question I'm going to have for each one of them is, Terence, one, so you have this product that's working great, and then they say to you, you know what, we're going to increase the price by 75%. So now you're dependent on it. It's like an addiction. How do we protect against that, especially when the AI company doesn't want to give you the protections you're going to tell us about, okay? Two, Hassan, I'm going to ask you, so you get a phone call from a client. It would never be White Plains Hospital. They're perfect. But from a different client who calls up and says, we got a problem. The x-rays it's wacky. We're getting crazy hallucinations. So I'm going to want to know from you, what is the SWAT thing we do? Or what's the first thing we do? What's the second thing we do? And then what's the third thing? And then, Matt, my question to you is going to be, what advice can we give the audience when people are clamoring you for solutions that you don't think are appropriate, that they don't fit in your environment? Okay, so those are going to be the three. We're out of time, so you can't answer. And if you want to know, you got to come back at 3:30 and hear those questions. So I want to thank our panelists. This was really great, and look forward to speaking to you later. Thank you.